So let's take a look at reproductive physiology, and we're going to do this by looking at the development of the system before we start looking at the regulation of the system. So the system is going to start to develop around 5 to 6 weeks into gestation with the formation of the prototypical gonads. In a brief period after the prototypical gonads form, there will be spikes of testosterone that will lead to male differentiation within the urogenital organs. This will be followed by secondary changes that will take place over the next few weeks, where we will actually start seeing morphological changes between the male and the female at around 10 weeks. This is due to a set of Y associated chromosomes, the SRY, the TGIF2LY, and the TGIF-LY, as well as the PCDH11Y genes. What these genes do is that they lead to a differentiation away from what we deem the neutral gonad to be, and the neutral gonad is the female gonad, and this change based off of spikes of testosterone leads to changes of the urogenital morphology as well as the neuroanatomical morphology. The change within these two structures is what leads to the identity of various types of gender associated with urogenital anatomy. The initiation of development of the system from the neutral female system is why when we talk about regulation, we always have the negative feedback coming in from estrogen within the feedback loop. Now, some of the thing that comes out from this morphological differentiation that takes place is a societal labeling of genders based off of a separation of two distinct morphologies, a morphology that is either male or a morphology that is either female. The problem is that because it's originating from this neutral developmental sequence, and the spike of testosterone is not necessarily linked to genotypes, we can get spikes of testosterone that are present in a XX or a female genotype, or we can lose out on the spike of testosterone in an XY or in a male genotype, leading to a change of morphology where instead of having this binomial distribution where we have two distinct curves that do not touch, what ends up happening is we actually see something that looks more like this, where we don't have any clear delineation between male and female in terms of distribution. In fact, there's overlap. And this overlap goes from the most female female to the most male male with this overlap in between. And this overlap in between is what I was discussing a little bit earlier when we talked about the androphied female body image. And so the androphied female body image is within the female distribution curve in terms of urogenital and neuroanatomical morphology, but it's towards the male end of the curve. Now, this does not have anything to do with sexual orientation. This is in terms of attraction and mate want. This is strictly about reproductive system regulation and neurophysiological and neuroanatomical development, because there are some differentiations that will take place due to the spike or lack of spike as it relates to the regulation of the system, which we'll get to later on as it relates to pubertal development and gender and possible can lead to possible issues with gender identification. So in terms of the overall development of the system, we always start with the prototypical urogenital development. By 12 weeks, we have noticed that there is starting to have the initiation of the differentiation between male and female urogenital pathways, where at about 20 weeks of total gestation, there is full differentiation. Now, the testicles have not distended into the scrotum at this point in time. However, there is the full scrotal sac. But if you notice, all of the tissues within the structures all came from the same tissues originally. And it's why there's some of the anatomical similarities between the male and the female pathways. Now, when we look at the actual gonadal pathway development, it's slightly different. And it has to do with whether or not we're going to keep the paramesompheric duct or the mesompheric duct. And so this is going to lead to the differentiation between the male and the female in terms of the gonads. And so for the males, we lose the paramesenteric duct and we keep the mesenteric duct. And this leads to differentiation of the gonads and the uh, integration of the efferent ductules into the developing testes. Now, the mesenteric ducts are going to undergo atrophication. As they undergo atrophication, they're going to change a little bit in terms of their orientation. And so the paramesenteric ducts will become connective tissue that's going to surround the mesenteric ducts and the vas deferens and ductus deferens tissues. It will also lead to some of the connective tissue within the inguinal region. We will start getting some urogenital sinal development around the urethra, which is going to lead to elongation of the urethra and development of the bulbourethral glands and prostatic gland. Where at birth we get distension of the testicle into the scrotum through the inguinal canal. We get development of the seminal vesicles. We get development of the prostate gland and calipers, or the bulbourethral gland, that will allow for passage of the sperm and the ejaculate matrix. Now, this can be slightly different than what we see with the females. And so for the females, what's happening is instead of keeping the paramesenteric, instead of keeping the mesenteric, we keep the paramesenteric tissues. And because we lose that mesenteric duct network, because we lose the mesenteric stimulating hormones within the development, what ends up happening is that we don't have that direct connection point between the now developing ovaries and the pathway to the uterus, which is going to come from the paramesenteric tissue. We also get a separation of the urinary urethra pathway from the urogenital sinus, which means that the vagina and the urethra are going to be separate, even though they're going to exit through the same cloaca opening. Where at the terminus of development, we get the ovaries suspended within the broad ligament, which is the remnants of that mesenteric tissue, with the fallopian tubes and fimbriae oriented around the ovary, feeding into the uterine horns and the uterus itself, linked up through the cervical sphincter with the vagina, heading out into the vaginal orifice. Functionally speaking, this tissue will not become fully developed until puberty. During puberty, we get this secondary spike of testosterone, or we get an initial shock of estrogen. It's this initial shock of estrogen or the secondary post-fetal spike of testosterone, where if we did not get the initial shocks of testosterone during fetal development, can cause issues with hypothalamic mammillary regulation of higher cortical functions, and can lead to what some people refer to as the transgender confusion that will start to develop for children as they start to enter puberty. There are two distinct things that are necessary for female puberty to take place. One of them is the initiation of ornamental fat depositing, particularly around the pelvis. This ornamental fat is necessary for enzymatic functions to allow for the development of estrogen and estrogen spiking. For both males and females, we will see distinct musculoskeletal adjustments, as well as the development of post-secondary or reproductive characteristics. So the last differences that we see in terms of the developmental side on the male and female reproductive system has to deal with what's referred to as the urogenital and the anal triangles, where males tend to have a very steep triangle, whereas females tend to have a very broad triangle. And this has to deal with the changes that we see in puberty that relate to the ability to maintain the stable platform during gestation, as well as to the partial changes that we see as relates to birthing issues, where the urogenital triangle is a hard border made up of the pubic symphysis and the ischial tuberosities, whereas the anal triangle is more of a soft tissue triangle that's bound by the ischial tuberosities and where the coccygeals would be around the anal sphincter. Within the urogenital triangle, there are three distinct muscles which make up what's referred to as the pelvic floor muscles. These include the ischiocavernosus muscle, the bulbous spongiosus muscle, as well as the superficial transverse perineal muscles. These muscles will form the base region for the penis for the male and will provide the pelvic floor muscles that surround the labius for the females. Both of these muscles are able to, for both males and females, all these muscles are able to be cognitively regulated and trained, you can put quotes around that, by a series of muscle exercises known as Kegel exercises. Now, Kegel exercises are usually associated with female reproductive health following birth, as it's used to reestablish the urogenital and anal triangular structures. However, for male sexual reproductive health, Kegel exercises can be utilized within the normal uh, treatments for erectile dysfunction issues, as the more the muscles are utilized, the greater the blood flow will head through those tissues, increasing the likelihood of having correct erection and reducing erectile dysfunction issues for the male.